just to give you a bit of background about I'm from London, Ontario. I did my training here in Ottawa and in London, Ontario, and my fellowship in London, England. So I did cancer therapeutic development in London, England for 2 years before I started on staff here. I've done first in human, clinical trials for a long time. And so a huge background in clinical trials. I currently run phase 3 clinical trials, some of my own I'll describe to you in North America, but I'm part of the Canadian Cancer Trials Group, which is looking to bring new therapies to Canadians. So I like to start with some take-home points just to know where we're at. And first of all, unfortunately, stage 4 incurable metastatic prostate cancer is increasing. And part of the reason for this is because over many decades, there have been changes in practice in how we screen for prostate cancer. Of course, we've been trying to prevent overtreatment of prostate cancer and therefore doing less PSA screening. But as a result, when you're in my practice, you end up seeing some underdiagnosed stage 4 cancer. So we're seeing that since 2010 increasing. That's US data.
Excuse me, when you say incurable.
Yeah.
Like
when it's spread beyond the prostate, okay? It can be controlled.
Okay.
You can be on therapy, hormone therapy for a long time, but can we stop the hormone therapy? I think it's the main question there. Another thing is that we have more advanced hormone therapies than ever. We have chemotherapy for many years, have been an important tool in controlling cancer, but we really need a lot more studies to know who should we be giving more therapy to, who should we be giving less therapy to. We also have new therapies coming on board that I'll speak to you about. And so we want better outcomes, but we need to personalize treatment more and more now that we have new tools. Next slide. One promising approach to this is actually using biomarkers, and there's no more widespread biomarker and cheap biomarker than PSA, right? We're using PSA all the time to inform if you're responding to treatment, if you don't have any activity of the cancer. And we think that what we should be developing is approaches where we give patients treatment, evaluate how they're doing, and then decide if we need to do even more to get their prostate cancer under control. So, okay. So here's get into the main presentation. I work at the Ottawa Hospital Cancer Center, and this is a 1.1 million population in Ottawa, 1.6 metropolitan. We're very centralized. So everything really, all the cancer comes in centrally. We're seeing them all, generally in one building. There's 26 medical oncologists like myself that do work across all cancers. There's 6 medical oncologists that specifically deal in prostate cancer at the Ottawa Hospital, and we have a large clinical trials team. So we're really delivering care for the whole region. That's a bit unique, that's not every cancer center that is just so centralized. It has some advantages and disadvantages, I'll tell you. The next slide, please. In the medical oncology practice, what I see a lot of advanced prostate cancer, right? So a lot of questions I get are, how did it get this far that you have to see me, a medical oncologist, in order to try and control, the disease? And that's, as I said, it's a complex equation, right? By the time they get to me, they've already had diagnosis, they've already had staging scans, patients. And the answer is that it is complicated because there's a lot of prostate cancer that isn't that aggressive, right? There's a lot of prostate cancer that may take many years to become more advanced, whereas some prostate cancer is very biologically aggressive. So the time from no spread of cancer to a body full of cancer like this PSMA PET scan shows can be within 1 year. So that's if it's that aggressive that's happening within 1 year, there's no PSA screening test that's going to help. So so this is illustrating this point. So this is Canadian cancer statistics. So nearly 28,000 patients will be diagnosed with prostate cancer each year, and 5,000 patients die of prostate cancer. So that means there's 5 times as many people diagnosed with prostate cancer as will die, and patients will probably and thankfully maybe die of other reasons than prostate cancer. So there's this gap, right? So some patients may get too much treatment for their localized prostate cancer, but yet there are patients dying of prostate cancer. So we need to separate out who's who, who needs more treatment, who needs less treatment. Next slide, please. And so this is a graph of what's happened since we've made changes in PSA screening, right? So over the 1980s, 1990s, we've been ramping up PSA screening. And then around 2009 or so, 2007, I think, there were recommendations to decrease PSA screening because of over-treatment of patients with localized prostate cancer. But the result is really that as you're decreasing PSA screening, as I showed later, then your stage 4 diagnosis does start to go up as a result. Okay, now we're getting better at treating stage 4 cancer, but one approach that would be nice is if, of course, you don't get to see me in the first place. Okay, and we are making advances in that. Next slide, please. There's also a bit of stage migration now that we are coming with better imaging. Our usual tools to look for spread of prostate cancer is CT scans and bone scans. Okay, usually we use those. But nowadays we have new tests, and this is an example one called PSMA PET scan. So PSMA stands for prostate-specific membrane antigen, and it's this sort of flag on cancers that's largely restricted to prostate cancer, and is a very useful tool to do something called functional imaging. Okay, so what they do is they have this little tracer for PSMA, and they attach a little radiation molecule, usually like gallium-68 is an example, and then they image where in the body there is some prostate cancer. And so you can see in this image, there's a CT scan, and they overlay this tracer uptake on top of it. And you can see right there, there's a little, there's this tiny little lymph node that you can see in the pelvis that actually we weren't as aware of based on the regular CT scans. And that is causing something called stage migration. Okay, so you have, and we can't see this too well because of the screen, but if you have negative bone scan and CT scan, sometimes you can have positive PSMA PETs that now lead to us calling this stage 4 prostate cancer. That's also increasing the amount of disease. And that's a good thing that we have more tools to let us know where the cancer is. I think the questions are, well, what should we do about this, right? Because now we can find tiny bits of cancer. And should we shoot radiation at everything that we see? That's certainly one approach that is very promising. Should we be giving some of these new PSMA radioligand therapies? This is all going to be a huge, new area in prostate cancer treatment. So, next slide, please. So the natural consequence of the things that I've said is that we've been doing less PSA screening, so we're diagnosing less people at the early stage. We're diagnosing more people at the recurrent prostate cancer or newly stage 4 cancers, and we have to do a lot more chronic management, a lot more hormone therapy, a lot more treatment as a result of that. Next slide, please. So this is the current landscape, thank you, of how we're treating prostate cancer. And we really define for stage 4 prostate cancer, we define hormone sensitive. Okay, yeah, so we normally talk about hormone sensitive prostate cancer and resistant prostate cancer, or castration resistant prostate cancer. And so this is when when patients have a first diagnosis, and the tools, as I said, when you have a first diagnosis, is to start hormone therapy, but then a second hormone therapy agent, and plus or minus chemotherapy, plus or minus radiation treatment. Okay, all in an effort to control this cancer as long as possible. We want this phase of the controlled prostate cancer to be as long as possible.
But you're stage 4 then?
Yes, for this situation, is stage 4. You may have very well have gotten localized prostate cancer treatment, radiation or surgery, plus or minus hormones at that point, right? But that's all for localized. Now, if the PSA starts to go up and say some of the scans are then positive, then you're metastatic, right?
Okay.
Yeah.
At the stage 4, your biopsy is Gleason.
It doesn't matter what the biopsy is, although, there's a tendency for metastatic prostate cancer to be more on the aggressive side. So that'd be 8 to 10, right? Sometimes 7. So it's hard to say because, a biopsy is only a sampling, right? So within one prostate cancer, you can have a mix of cells, maybe like 95% of it is, very, Gleason 7, not that aggressive. But what if 10% of it, 5% of it was Gleason 9, right? So sometimes those 9 cells can escape, and that is what leads to this coming back. So cancers are difficult to pinpoint sometimes because they're so complex, right? So all this, and thankfully, for this room, this very well may not be relevant to you if it's not metastatic disease, which is good, right? Well, but what I'm saying is that, in our world, we're seeing a lot of metastatic prostate cancer, okay? And so this is currently what approach we're taking, but there's a lot of new therapies that we look at, right? So the Pluvicto, PSMA, lutetium, radium, PARP inhibitors, immunotherapy, immune checkpoint inhibitors, and now coming in the clinic, bispecific T-cell engagers, antibody drug conjugates, androgen receptor degraders. If this is like, do you know how much money is going into prostate cancer research? It is like a very complex area, right? And the question is, how is that going to ultimately impact what we do at first diagnosis? And is that going to make a big difference in lengthening the amount of time that we have control of the prostate cancer? That's really what we want, is not to be treating just resistant prostate cancer, because that is a very difficult situation. Okay. Next slide, please. Yeah, so data, sorry, this is a complex slide, but I will summarize because you only need to look at the margins. Okay, these are all the clinical trials that have led to the approval of chemotherapy and hormone therapy for metastatic prostate cancer. Okay, and the bottom line is adding in chemo to hormone therapy improves survival rate by 25%. Adding in a second hormone drug improves survival rate by 35%. And actually the combination of the two, well, it's actually difficult for us to pin down exactly how much chemo contributes, but it seems to be 25% even better, okay? So that's what we're currently, doing as initial treatment. Next slide. And the idea, and you can see some of the results here. This is from the ARCHES clinical trial. And in the green curve, you have just hormone therapy, like androgen deprivation. So this is like Zoladex, Eligard, Lupron, all those, it could be Relugolix these days, or Firmagon, some of these drugs, okay? If you just give those drugs I just listed alone, half of people are alive at 5 years, okay? And with this addition of a second hormone blocker, in this case, enzalutamide, we're pushing survival, another 13% at 5 years. So that's really leading to not only a lot better survival, but a lot less progression of the cancer. So we're giving these hormone therapies for longer and longer. And our question is, well, how can we push this even farther up? And, that's where we're trying to figure out what's the role of adding in standard chemotherapy to that mixture, because, it's great if you're in this group, but it's not so great if you're in the top half in the purple curve. Sorry, the upside of the purple curve. So next slide, please. So what we currently do to try and decide about adding in chemotherapy or not, like ideally we would know if we have cancers that are very sensitive to hormone therapy, and that's all we need to do, okay? And that's the top here. We select patients based on how many spots of cancer that they have. So it's like, only 3 or less spots on the bone, or no liver or lung metastases, we'll just give them hormone therapy. Whereas if we have many spots in the bones, liver or lung metastases, or maybe some features that are very aggressive, we'll decide, hey, we think that chemotherapy may be important to add. The problem with this approach is, of course, this is not an actual test, right? We are not taking a sample of the cancer, analyzing its, features, and then making an informed decision as to whether the chemotherapy is going to be helpful, right? We're just guessing based on how many spots of cancer we see. And that's what we want to try to get away from. And there's a lot of work being done in this area to try and pick better, but we don't have something that is quite ready, but this is the theory, okay? Next slide, please. Well, one promising approach that I said is what we should do is actually look at the response to treatment, response to hormone therapy, to see how well it's going, to decide whether or not we need to add something. Okay, so here's old data from this Southwest Oncology Group. It's a US cooperative group, saying that when you start normal hormone therapy, like this Zoladex, those kind of therapies, the PSA at 6 to 7 months into treatment is really, really important to tell how well patients are going to do. Okay, so if your PSA is over 4, patients are living only 1 year. And if patients are under 0.2, the average survival is 6.25 years. And that's based on the old hormone therapy data. Okay, now when you look at new hormone treatments, so that in this case it was apalutamide, in this case it was abiraterone, we can push the PSA under 0.2 from 10% of people. We can push it up to 55% of people. Okay, so we're actually pushing a lot of people into this much better group and with better outcomes. Next slide, please. So I looked at this data in our international Ironman registry. I don't know if any of you know about that registry, but you may remember the Movember campaign for prostate cancer. Any hands up for if you remember that Movember campaign? This is unfortunately me as part of that Movember. Yeah, I'm sorry, that's my wife there, but she's not too happy. But it was, you're supposed to grow a mustache in November. You raise some money for prostate cancer and now men's health, right? So one of the huge projects that the Movember campaign funded is this international registry of men with prostate cancer. Okay, so to date, there's almost now at their target, almost 5,000 men in the world that were enrolled in this study with both hormone-sensitive prostate cancer and resistant prostate cancer, all metastatic, okay, not localized prostate cancer. 123 active sites, 15 countries. And so, samples were collected over many years. Next slide, please. And so this is what the registry looks like. I mean, 16% from Canada, including our site in Ottawa. We have nearly 100 men at our site. 40% from the US, but a large cohort from Europe, and some from Australia. And there are actually African and South African South American countries. What we did in my analysis was we took everybody that was getting the new advanced hormone therapies. Okay, so we were getting regular androgen deprivation therapy, but also the androgen receptor pathway inhibitors, so double hormone therapy. And so we isolated 1,219 patients getting this double therapy. Okay, the next slide, please. And this was the cohort, 74% Caucasian, 8% Black, 2% Asian. Gleason 8 to 10, kind of to your question, 58% had Gleason 8 to 10. 75% had metastatic prostate cancer from the get-go, right? No local treatments prior. Okay, so it is more aggressive prostate cancer. So only 27% had prior prostatectomy or radiation to the prostate. And largely, as you'd expect, bone metastases are part of the problem. And then lymph nodes, lung, and liver, okay? And what were patients getting? 88% the double hormone therapy, 12% got the additional docetaxel chemotherapy. And these were the drugs involved, so abiraterone, apalutamide, enzalutamide, darolutamide, okay? So all the drugs. So what did we find? I'll show you the next slide, please. So as we were saying, this concept was 6 and 12 months. At 6 months, half of people have a PSA under 0.2, which is great. In fact, 1/3 of patients were having a PSA under 0.1, okay, at 6 months. And at 12 months, 2/3 of patients had a PSA under 0.2, half the patients under 0.1, okay. Why is this important? We looked at when we got to this point, if your PSA is over 0.2, we saw that there was a standout. This is a Kaplan-Meier curve, so this is how patients are surviving from this point at 12 months. And you can see that if your PSA is over 0.2, there's a big drop-off in survival, meaning the cancer is behaving much worse. And if we're identifying patients with a PSA that's high at 12 months, or even at 6 months, we should be escalating therapy. We should really be doing more about this group. The other flip side is if your PSA is under 0.1, 84% 3 years, I mean, that's actually very good if you've got metastatic prostate cancer. This is a real world registry. The clinical trial data is even better than this. So if you're getting under 0.02, I mean, patients are living many years on hormone therapy, and we actually have the opposite problem. Okay, we start having side effects from chronic hormone therapy, muscle loss, bone loss, even cognitive side effects that we need to start to attack, right? We need to start managing these. If you're going to be on hormone therapy for 3 years, well, maybe it's not as present. What if you're on hormone therapy for 15 years? Well, there's a consequence to that, right? So I think we have to actually think of both sides of the coin. Next slide. And so this is a randomized clinical trial just showing the lower is better, okay? So less than 0.02 in this study. Look, their survival outcomes, again, very good if you're having the ultra low response. So I argue that there's so much data in this realm that we really need to be more proactive, not just waiting for, give one therapy, and then if it doesn't work, and things progress, and then add in another therapy. We should actually be targeting the PSA, if it's not there yet, let's give more therapy because we're not there yet, right? Okay. Next slide. And so what is the approach that I've been pushing internationally? We've been pushing this idea that, okay, if we have hormone-sensitive prostate cancer and you're getting very good results, you should be looking at doublet therapy only, and maybe even taking breaks from treatment, okay? Whereas if you have more aggressive disease, your PSA is still high, we need to add in more therapy, like maybe docetaxel, but actually there's a lot of new therapies coming on board that I'll describe that we may be able to apply these approaches. Next slide. So this is my clinical trial. It's an international study where we look at patients that are getting double hormone therapy, metastatic disease, receiving any of these hormone therapies, and then their PSA is still high. And we're actually randomizing patients to be adding on docetaxel chemotherapy to prove to the world that it's worth giving chemotherapy added to these men with prostate cancer if the PSA is still high. And the primary objective is to show that we are improving survival by at least 1 year on average by adding in 3.5 months of chemotherapy. So it's a short course chemotherapy. The idea really is you're still seeing PSA that's high, kill off some of those cancer cells early, and then it's going to take a lot longer for resistance to happen. And so this trial is called Triple Switch. This is my co-chair in Portland, so it's an exciting trial. It's open at 250 sites across North America, so including ours. Not a surprise. Next slide, please. So what's happening with more other new therapies or for more personalized prostate cancer treatment? There's so many. I mean, I think we're looking at new androgen receptor therapies, so like therapies that break down the target of testosterone, right? When testosterone, how testosterone stimulates your prostate cancer is that it is a hormone that goes into the cancer cell and binds to this androgen receptor, which is sitting in the cytosol of the cell. And once that dihydrotestosterone plus androgen receptor gets together, it goes into the core of the cell, the nucleus, and signals for it to grow and spread and do bad things, okay? Mm-hmm. So, we've been spending our entire careers trying to block that androgen receptor, but there are actually new therapies that can just try to break it down altogether, just have no androgen receptor. And so that still is an important target. We know that there are other tumor suppressor genes that make it more likely that the androgen receptor is not the main signal that prostate cancer is growing on. It's not fueling just because of hormones. And so when we can identify that, we need to include therapies like chemotherapy or other new therapies. We're spending a lot of time looking at these genes that repair DNA, okay? So BRCA1, BRCA2, these are classically associated with breast and ovarian cancer, but they are DNA repair genes. And when we find that a cancer has a change or a mutation that inactivates these DNA repair genes, we can actually capitalize on that. We can actually give drugs that cause DNA damage that the cancer can't repair. Okay, so one class of that is called PARP inhibitors, and there's new data now showing PARP inhibitors work in prostate cancer. I'll show you a bit of that. Larry is here because he was identified to have one of these mismatch repair genes. Okay, this is a different kind of DNA repair, but when you have mismatch repair gene deficiency, your cancer accumulates a lot of mutations, okay? And then your immune system won't like that. Your immune system thinks, well, that's a very ugly looking cancer, and it'll try to attack it, and we can give drugs that help that along. The only challenge is that it only seems to be 3% of metastatic prostate cancer that have this kind of natural reaction. So we're spending a lot of effort at the Ottawa Hospital to screen everybody for this mismatch repair deficiency. I was bemoaning the fact that we had tested like nearly 100 patients in the last 6 months for it, and we weren't finding anybody, but the moment I complained, I found one person with the gene. So there you go, Larry. We're making progress to identify more candidates. And then I won't go over that. This toolbox of many different therapies, it's huge. It's just a question of how and when are we going to use these new therapies. So next slide, please. So this is another busy slide, but I'll summarize by saying that there are many new therapies for initial treatment of metastatic prostate cancer that are being reported even as we speak. Okay, so when I was in Chicago just this July, I was part of the presentation where this trial was presented, the Amplitude. This was that PARP inhibitor trial, which is for the patients with BRCA mutation or other mutations, and it was shown to be positive. It delays progression of cancer. It's published now in Nature Medicine. And so PARP inhibitors on top of double hormone therapy work. And we're waiting for the overall survival data from that trial. But this is going to be another tool that is going to be part of our toolbox very soon. There's two other PARP inhibitor trials. One is talazoparib and enzalutamide. So a PARP inhibitor with enzalutamide. This is already positive as well. And we're awaiting the final paper and the presentation, but that's reported positive. We are currently finishing off the enrollment for EvoPAR. So this is another next generation PARP inhibitor that's hopefully going to have less side effects. But accrual completed. So we're actually, one of the leads of this is Kim Chi from Vancouver, so the Canadian principal investigator. So we think that this is going to be part of the toolbox. PSMA addition, this is the use of Pluvicto in newly diagnosed hormone-sensitive prostate cancer. This is going to be reported in Berlin this weekend, okay? So we're really hotly anticipating that result. It already has a press release saying it's positive, okay? And Capitello 281 is going to be presented. It's only in one of these tumor suppressor gene loss biomarker defined groups, but it's also positive. And then the Cyclone 3, I don't think it's going to be positive because Cyclone 2 was negative, but we're still awaiting the results of that one. Okay, so there's just a lot of activity, a lot of new options that we're anticipating will come. Next slide, please. And here's just a snapshot of it. Like this is, progression-free survival in BRCA mutated cancer. It's a 48% improvement in the rate of progression in this study. So that's it's an impressive result. Next slide, please. The only problem to Amplitude is, some of these, once you get very personalized with your choice of therapy in prostate cancer, it may take you a lot of testing in order to identify the patients that are going to benefit. Okay, so in this study, they enrolled 696 patients. They had to screen over 6,000 patients to identify the patients that went on the study. That's like 10 times the number of patients that you had to do a gene test in order to identify, okay, well, you qualify. And that's, that's a lot of, if you're a patient and you're waiting for that test and, you don't, like 90% of the time, you don't qualify, like that can be disappointing, but also leading to delays.
And you have to pay for that gene test.
No, that depends. Sometimes yes, sometimes no, it depends. The problem with paying is you don't have to pay if it's a validated test, but there are a lot of other, targets that are probably going to work, but maybe it doesn't work. And if you want the full package of everything, even the stuff that maybe isn't going to predict if the drug works, then you might have to pay for it. It also takes time for us to get these tests approved by the government too. So it's, you're always playing catch up, but we have access to testing. It's free. People don't have to pay for it. And another problem with this drug is it does cause some significant anemia, low blood counts, and some gastrointestinal side effects. So if you were already going to do well on double hormone therapy, why would you want the extra drug, right? So I think this is the question that we're asking. Yes, the rate of progression is better, but did everybody need it? What if your PSA was already going to get to zero without the treatment? Is it worth all these side effects? So there's a lot, even when we get positive data, there's a lot of questions that come from that. Next slide, please. And then I talked a bit about Pluvicto. This is Pluvicto. So you've got this PSMA, prostate-specific membrane antigen flag on the cancer cell, and then you attach a radiation molecule to it. So when you inject this therapy into patients, it's supposed to hone in on this flag on the cancer cell. It gets internalized, and then it delivers damage directly to the cancer DNA. That's how it's supposed to work. And the hotter your PSMA scan lights up where the metastases, the more of this radiation that's directly delivered to the sites of metastasis. So this is the trial. Next slide, please. this is the trial PSMA addition that is reportedly positive, and it's going to be reported this weekend. You can even search the news, the PSMA addition, to see what the results were. I don't think it'll be a surprise, because the primary endpoint is radiographic progression-free survival, so it's going to be improved by the addition of this therapy. I guess the question is how much, right? Is it 30%, or is it 50%, or is it more? So we're hoping for more, of course, but we'll see. Next slide. And then there are, actually, I've talked a lot about adding in more therapy, but there are actually huge efforts to try and give less therapy as well. So this is a European study called De-escalate, and again, metastatic disease, where if at 6 to 12 months, your PSA is less than 0.2, in this study, they randomized patients to taking a break, okay? So you either continue your hormone therapy or you get it once in a while, okay? So that you can get testosterone recovery, you can feel a bit better, and hopefully what they're hoping is that patients can safely take a break and their survival won't be impacted by that approach, and that their quality of life, patients' quality of life will be better with that approach. Okay. All right, so that's it for my talk. If you want to just go and take home points, we're seeing more stage 4 cancer. Next slide. Next slide, please. Yeah. And our current therapies are hormones and chemo right now, but 6 to 12 months from now, actually, we might very well be adding in PARP inhibitors and Pluvicto, which we're already giving. So you can see how quickly things are moving here. And next slide. And we are leading in Ottawa clinical trials that are poised to change how we approach this disease, using 6 to 12 month PSA to cater treatment, more or less. And that work, thanks to Movember, thanks to the Canadian Institutes of Health Research, the Canadian Cancer Trials Group. So that's it. Next slide, please. That's if you got time, you got 15 minutes for questions. I'm joking.
I understand the role of ADT, but what does chemo do?
Yeah, so the effectiveness of androgen deprivation therapy, or lowering testosterone or blocking testosterone, is entirely dependent on how much your cancer cares about testosterone. And as you develop many, many more clones of cancer, some of those clones may not care about testosterone at all, right? So if you give a testosterone blocker and the PSA doesn't go down, you have to question whether actually that cancer cell needs to be killed off by something else, right? So there are many potential growth mechanisms that are independent of the androgen receptor. Do you understand?
And chemo attacks those.
Yeah, so chemotherapy is a widely studied, effective treatment to kill off some cancer cells, okay? And one of the most influential studies in prostate cancer was presented in 2013, and was called the CHARTED study. At that time, our approach to metastatic hormone therapy was only give androgen deprivation therapy, okay? And usually, 2 years later, PSA is worse, and we started to give treatments like chemotherapy, okay? And chemotherapy really wasn't that effective in the resistant setting. It improved survival by 2.5 months in one study, okay, on average. Well, that's not very impressive at all. Whereas in that study, we added 6 cycles of chemotherapy early, right at diagnosis. It improved survival by 17 months on average, okay, in that trial. And that was a huge paradigm shifting study, because we always thought, well, we'll just give the treatments later when things are resistant. What we're saying now is, don't wait for things to become resistant. You have some resistant clones, get rid of them now, right? There are many ways to try and get rid of them. Radiate them all, right? Add in chemo, add in PARP inhibitors, add in Pluvicto, try to give immunotherapy, right? So that we have many things in our toolbox, but what we're, how, we don't just approach however we want. We need to generate data to show that it's effective, right? That's how at least Western medicine works, right? So that's what we're trying to do, clinical trials to prove that these approaches are important, okay? And then, of course, even for hormone therapy, we question, do we always need double hormone therapy? Because actually, in the old days, when we started androgen deprivation therapy, we always had 20% of people that actually never progressed. Like they did hormone therapy and the cancer never got worse. And 8 years out, 10 years out. So why do we need the second agent? Well, it's to boost those numbers. But there are some patients that actually maybe don't need that duration of therapy. Or, we talk about this in the medical oncology circles of like, well, if I've been double therapy, PSAs are nothing, scans are negative after, after 3 years. Can we take a break or shouldn't we take a break? Or should we do, should we have radiated everything and try to take a break more deliberately? So I think that there's a lot of nuance now to, what we're doing. So recently, I unfortunately had a patient was diagnosed in late 40s, right? Maybe, I can't remember, 46, metastatic prostate cancer. Putting him on androgen deprivation therapy, now he's been on for 5 years, no hint of cancer being active. He's, taking the decision, I want to take a break. I want to see if things are going to be controlled. If break even works, like I feel any better, right? Because his whole mentality shifted, right? Like his used to be sort of this aggressive businessman, and his personality's changed because of hormone therapy. So
Is hormone therapy only for metastatic?
no, so not at all, because if you're giving radiation, for example, for high risk prostate cancer, that's coupled together with hormone therapies. And every single double hormone therapy that I've talked about has been tested in high-risk prostate cancer, or even, maybe other prostate cancer settings that have some other risk factors. And there's no doubt that any indication for androgen deprivation therapy, you could probably augment the results with a better blocker of hormones, okay? So double hormone therapy is going to be better from a prostate cancer point of view. That doesn't necessarily mean that it's a better approach to take, because it adds side effects, and you may have other comorbidities like heart disease or that might be competing, that may not make the eventual outcome any different if you add in more.
Well, just local in the prostate, there's no immune therapy,
Immune therapy?
hormone or therapy.
Oh, well,
Just for local.
yeah, absolutely. As I said, like if you have localized cancer and you get radiation for that, and it's called a high-risk cancer, then we routinely add in hormone therapy.
Okay.
Routinely. And then of
So
course, if you have localized cancer, you get treated, but then there's a biochemical, there's a PSA rise after that, and nothing on your scans. You will also get hormone therapy. That's still localized, but there's some cells somewhere you can't always find where they are.
We were speaking about the PEG testing
Yeah.
scan,
The PET scan.
PET scan. So is that an advantage to have that done and to know exactly where the cancers are and then do the due process?
Yeah, it's a very new field, and a lot of the use of PSMA PET scan is largely localized disease like biochemical relapse to identify things that you can radiate and salvage. And then, of course, now more and more we're using it to screen patients for eligibility for Pluvicto. Right.
I had a PMSA PET scan in 2019
Mhm.
that identified lymph nodes,
Mhm.
which had some of those removed from.
Yeah.
Dr. Moore, and,
Yeah.
now I'm just on intermittent hormone therapy,
Mhm.
but, had radiation several times.
So that's what I'm saying, like our new approach these days with these new scanners, try to identify everything we can see, radiating it and or taking it out early, right? With a good PSA result can lead to a long time to resistance. We don't know, you know, I don't think they necessarily say it's safe to stop the hormone therapy always, right? But, that's what we're sometimes on our minds, right? When is it safe to do those approaches? So,
So maybe a general question about the immunotherapy.
yeah,
So like how assuring this immunotherapy for the prostate cancer? From my basic knowledge, really, you get blood from the patient, you take it to the lab, whatever you do, create something and you put it back into the body on those, I don't know what you call them, they're gonna attack
yeah,
the cancer cell.
Yeah.
How can the doctor
Hmm.
be sure that this is not gonna go and attack other cell
Yeah,
and
yeah.
damage the whole thing?
Yeah, so that's a great question. I think that immunotherapy is not a new idea in prostate cancer. And we've done years of clinical trials that are actually failed largely for immunotherapy in prostate cancer. Okay, so we've given in the past immune trainers like ipilimumab. There's two major failed trials in that setting. And then we've given a lot of these anti-PD-1 trials that have also been failed, for the general unselected prostate cancer population. And then what you're describing, which is CAR T, okay, you basically try to take out the cancer, isolate the lymphocytes, train and activate them, grow them, and then infuse them back into the patient. Well, that's a super involved and expensive and potentially toxic treatment that has led to some people having responses, but it's not it's not proven yet that we should bring it to everybody, and it's also not feasible to bring it to everybody. That being said, we are definitely making roads or steps ahead to bring immunotherapy to patients with prostate cancer. So number one, we are screening for patients that have sensitivity to it, okay? So Larry is another example of us screening. So we did a complicated, you don't mind me telling the details, Larry, but we did a complicated approach in Larry in which we did a blood test. We tested for circulating tumor DNA. We sent it to Vancouver for analysis where they reported there's a high tumor mutational burden and deletion of these mismatch repair genes. He was screened positive. We enrolled him in a clinical trial to give him a specific immune therapy that worked great, and PSA is undetectable, and there's no evidence of disease on the scans. Okay, so as a metastatic disease has been beat back. So that's augmenting natural immunity, okay? Because all we're doing with that immunotherapy is we're removing a cloak that cancers express when they get attacked by the immune system, okay? But it doesn't cause the cancers, it doesn't cause the lymphocytes to want to attack the cancer, okay? Are you following me? Like you're in your house and there's a burglar, you're attacking it and it's putting this cloak around itself and basically you're giving a drug that's removing that cloak, okay? But if you don't have that, if you have a burglar in your house, but you don't identify it as a burglar, then, your treatments don't work, okay? And that's the case for 97% of prostate cancer, okay? And so when you have that situation where the body wants to get rid of that cancer, we have more than just one type of immune therapy. We have double immune therapies, even triple, but we don't have enough patients to really tell us exactly which is the best combination, so they're all being tried, okay? Now, there are many new generations of immunotherapy, and I'm looking to bring a new clinical trial with something called a bispecific T-cell engager. Okay, so what this therapy does is it actually uses PSMA. Oh, no, sorry, no, this uses KLK2. Okay, it's a target on prostate cancer cells. And it is a bispecific T-cell engager, so it has one end that links to the prostate cancer and another arm that links to lymphocytes, like white cells. And so when you give this treatment, well, you're just trying to link these white cells to cancer. And just by doing that, it squeezes those white cells to release some inflammation around the cancer. And lo and behold, the early data shows it's making PSA go down, it's shrinking some cancer, we're getting some results. So now we're doing a randomized trial to see if, this is actually something we should incorporate in our treatment. Okay, so there's at least 2 agents in phase 3 trials looking at that approach. The dangers to this immune therapy approach are you can cause something called cytokine release syndrome, which is like you're getting a bad flu, or even worse, an allergic type reaction. And so we have to monitor patients in hospital and give them antidotes sometimes. So it's, so these are things that we're testing. They're not approved yet. So there's definitely work still being done in immune therapy. It's just not an easy thing to do. So I've had some inquiries from the National Research Council to develop some totally novel immune therapies in the lab, which is cool, but that will take a decade or so to come to fruition. So come back in 10 years, I'll tell you what happened.
We have.
Just if I could say, I've been treated with radiation, chemotherapy, and androgen therapy, and I'm cancer-free at this point. I was treated for 2 years. I finished the treatment about 6 months ago. I want to thank Dr. Ng for presenting this in an understandable way. I thank him very much. And I just wanted to say my treatment was a success, and I'm expected to recover from the prostate cancer I had, and I had a high dose of prostate cancer. Thank you.
Just wanted to ask, you've talked about quite a number of different types of therapy. Are these clinical trials, or if somebody is diagnosed with like a stage 4 metastatic cancer from the outset, are they directed to you to
Yeah,
figure out
absolutely.
which therapy might help them?
Yeah, absolutely. So, I mean, we have tried to comprehensively screen everybody now for therapies that are available and covered. And some of the subtleties are that not everything that has a test associated with it may not be the entire umbrella of things that are approved. Okay, so for example, of all the, so I think you understand hormone therapies and chemotherapy, those are blanket approved for everybody. For PARP inhibitors, the strongest data is really for BRCA1 and BRCA2 mutations. We standardly test for ATM and PALB2 mutations, which have less good data that it works. And then there's many, many genes that could have mutations that actually aren't approved by Health Canada, could benefit, but don't certainly benefit. And those would include CHEK2, CDK12, RAD51. Like there's just a laundry list of genes that you test a tumor and you just don't know what to do with the result because you don't know what's going to work and it's not funded. So do you ask the patient to then fork out money to pay for a drug, right? So I think that's not Health Canada's fault. That's just the data is very messy and we don't know what the right answer is. Okay. Immunotherapy is another example. Immunotherapy, if I identified somebody as having high mutational burden, like Larry, in his blood, I couldn't get immunotherapy funded for that situation. But if I test the tumor for mismatch repair protein, then, and it's mutated, then I can get that drug funded, right? So there's lots of subtleties in what's funded and what's not funded based on how complicated like these treatments are. Pluvicto, for example, we're using it. The funding approval is linked to our multidisciplinary approval at our team meetings, and having a PSMA PET scan and having had prior chemotherapy. Okay, so we can't give Pluvicto before docetaxel chemotherapy on the label. So there are some restrictions in how we deliver that. So I'm just giving you a flavor of how complicated, it is, but there's a lot of testing and, it's increasingly complex. Yeah.
Is there any linkage between the melanoma gene mutation and I can't remember the name of the gene mutation and occurrence of metastatic stage 4 prostate cancer?
Yeah, so there isn't a very strong link between those two entities because, for example, the typical inherited melanoma gene is CDKN2A, like the familial atypical melanoma, family familial gene. Whereas, in inherited prostate cancer, it tends more to be, BRCA1, BRCA2, HOXB13, TP53. There's just many genes that we screen for. So there can be some commonalities in BRCA2 associated prostate cancer and BRCA2 associated melanoma, but that's very uncommon, right? I mean, it's like 4% of the whole population of patients with prostate cancer. So there's no like definite overlap.
Okay.
And I think that, with melanoma, what are the big risk factors, right? Being white, having a lot of sun. Does that necessarily associate with prostate cancer? Not really, right? I think, and then beyond that, yes, you can have genes that predispose you, but it's still, those are still the more major risk factors. So if you're in Florida and you're always getting sun, your chance of getting, head and neck melanoma is very high. And I see a lot of patients, unfortunately, with that. And then the other one is the young patients that get, burns intermittent damage, and they have BRAF mutated melanoma. So, yeah, so it's hard to sort out.
That's reassuring because I have a 50% chance of having that melanoma gene mutation. I know that. I haven't been tested yet. I'm going to test in a few weeks. But
yeah, we're testing, everybody with high risk or metastatic prostate cancer, we are testing their genes, their own genes, and the tumor genes to see if there's any of these alterations. So we standardly test 19 gene panel for inherited prostate cancer.
We have one more question online. This will be the last question. Thank you.
Hello. We just need you to unmute.
We're just wondering if Ottawa has a PET scanner yet.
Oh yeah. Ottawa has a PET scanner,
'Cause,
but Ottawa has a slow PET scanner.
I think we were told last year that we would have to go to Montreal or Toronto in the case of
the issue
getting a PET scan.
The issue is that we have old PET scanners, and I mean, they were acquired at a time where we did not need to do the number of scans that we are doing now. And this is not just the prostate cancer, right? In melanoma and lung cancer and, all kinds of other cancers, we're doing FDG PET scans. So my understanding is that there is capital acquisition of new PET scanners already underway, but of course it can't come fast enough, right? And so trust me, they're well aware of our limitations. So there are some centers that seem to be able to do a PET scanner like within a day or two, you know. And they built the capacity to do that. And so we've had to send our patients, for example, within Ontario, we sent some patients to Mississauga, which seems to just be able to do it anytime. But if, you know, if patients should have a right to choose if they want to get a PET scanner, then it's a few $1,000s to go to Montreal. And so that is the fastest way at times. And, you know, the technology has moved very quickly. And, you know, if you have to wait 6 months for a scan, you know, that's when sometimes I think you'd be advised, maybe you should go somewhere else. And that's not something we have definitely made it clear that we hope for better capacity, and my understanding is that is going to happen.
You're working to rectify that.
100%, because
Thank you.
trust me, I don't want to. I mean, I can't be ordering scans that are going to take that long.
Right.
But I mean, honestly, that's a huge problem, even when it comes to CT scanners and bone scanners and everything, you know. And part of it is sometimes not just the scanner. You know, apparently nuclear medicine technologist is one of the most difficult, coveted skills that they just can't hire to get enough of, you know. So it does not always just a scanner. So.
Okay,
Thank you.
well, thank you very much, Doctor, for coming and talk to us this evening.
Yeah.
And you've given us lots of information, and in over the next couple of weeks, the presentation will be online. So if you missed a bit of it, or you've had a mature moment, and said, what was that? It'll be up online. Thank you very much.
Thank you so much. Okay.